From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello and welcome to our listeners around the world. This is Dr. Eve Rittenberg, and you're listening to JAMA Internal Medicine Author Interviews. Thanks for joining us. Today, we're going to discuss metabolic-associated steatotic liver disease, or MASLD, which is now the leading cause of liver disease in the United States, and focus in on the Hispanic Latino community. In the U.S., the prevalence of MASLD and metabolic dysfunction-associated steatohepatitis, or MASH, is especially high among Hispanic Latino individuals. This in turn leads to higher risk of developing cirrhosis, hepatocellular carcinoma, need for liver transplant, and there's a complicated set of causes which raises lots of questions about how best to respond with individual patients, clinically, as well as on an institutional and policy level. So I'm really looking forward to talking with our guest today. Dr. Sammy Saab is the senior author of a review of MASLD and MASH in the U.S. Hispanic Latino population that we published recently in JAMA Internal Medicine. And he's a professor in the departments of medicine and surgery at the David Geffen School of Medicine at UCLA. Welcome, Dr. Saab.
Thank you for having me here.
So to start, could you just tell me why you were interested in writing this review?
So for a variety of reasons, some are personal, some are professional. Growing up in Southeast Los Angeles, of Latino parents, we saw firsthand the lack of awareness of fatty liver. People thought it was nothing. It was very common. Don't worry about it. But when those people started developing cirrhosis and liver cancer, it's a different perspective. So personally, seeing that evolution, family members and friends developing liver disease really struck a chord. And then professionally, seeing many people of Latino Hispanic backgrounds come into our office with the diagnosis of liver injury. And all they can say is, I don't drink alcohol. Why did I get liver disease? So it's a combination of professional and personal factors.
Can you help us understand all of the varying levels of contributors to the risk among Latino population? Because you talk in your review about all the varying groups that are contained within the umbrella terms of Hispanic or Latino, all the different social and cultural groups, all the individual factors. So how can we start to kind of piece that out?
No, great question. So unfortunately, Latinos represent the perfect storm with strong contribution of genetics. They have a genetic polymorphism that puts them at susceptible risk of developing liver complications as cirrhosis and liver cancer. Number two, as you kind of suggested, the second hit is metabolism. And so Latinos have a disproportionate higher rate of obesity, diabetes, and hyperlipidemia, as well as hypertension. All these factors are well known to be contributors to metabolic fatty liver disease. And Latinos are overrepresented in these factors. And the third piece of puzzle for the perfect storm is environmental. And unfortunately, many people of Latino background descent live in areas where there's a food desert, where their access to foods, particularly fresh foods, are severely limited. And they're more likely to see a fast food restaurant than they are to see a grocery store. So it's a perfect storm. And on top of all this, there's issues about access to care.
So I'm a primary care physician. I was struck by the statistic you cited that only 64% of Latino patients have a PCP compared to 79% of non-Hispanic white, 71% of non-Hispanic Black patients. And so thinking about the issues that are facing people in terms of accessing healthcare, accessing, medicine.
Yeah, so I'll give you an example. We recently had a health fair in the city of Inglewood, South Los Angeles, and we did translate elastographies almost on 100 individuals. And after the elastography, I would give in Spanish or English an update on their results. And I was struck about individuals who had diabetes who are not getting the right medications. And it highlights that there are some institutional differences in the way we treat different individuals. And it could be financial, it could be access to care, it could be a number of reasons, physician education, but there's a marked difference in how we approach diabetes in different segments of our population.
So let's get into that a little bit, like the clinical care. what should we be doing in terms of, even start with screening? How should we be screening for liver disease in our high-risk patients?
Because Latinos are so disproportionately affected by metabolic fatty liver disease, there is a very easy, straightforward test to do, and it's called the FIB-4. And basically, this is a mathematical model, includes your liver enzymes, your Asian platelets, and if it's elevated, it suggests there may be some liver disease, and then maybe it should be further investigated. If it's low, congratulations, your liver appears to be in good health. But if it's high, it's an invitation to further help the individual navigate the system and determine the severe liver disease. So the FIB-4, it's a great entry point into assessment of liver damage.
And relatively easy. Although I think you talk about some kind of subtleties and how to apply it in Latino patients in particular.
Yeah, so one of the things we realized by combing the literature is, the FIB-4 is used by every single medical society to identify people with high risk liver disease, whether it be Japan or Mexico or China, doesn't matter, across the whole world. But there may be nuances that doesn't serve our Latino community well. And one thing we argue about in our review article is that threshold for identifying those people at high risk should be lowered. And this way, we have a less of a chance of missing liver disease because there's so much diabetes, so much hyperlipidemia, so much hypertension, so much obesity that people of Latino background descent are particularly at risk of liver disease. You mentioned that MASH and MASLD are important causes of liver disease. I want to remind the audience that metabolic fatty liver disease is a real problem. It's the second most common reason for transplant in the United States. Among women, it's number one. And yet the challenge I have is that many of our colleagues who trained 10, 20 years ago think it's a benign condition. So we need to have a better effort to increase awareness.
Mm-hmm. There's so many different pieces. You talk about screening and awareness among clinicians, but also the pieces of this social determinants of health that are sort of beyond the individual clinical level, right? Like, how do you improve access to healthy food? How do you improve opportunities for exercise, et cetera? How do you, have access to healthcare overall?
I actually organized a health fair, and I'll be honest, when I left, I actually looked frustrated at feeling how small I am into this whole equation. And you're right, this to be done at a policy level, maybe as a quality indicator of practice to discuss social determinants of health, to discuss what are the proper tools for screening, what are the proper medication. But I'm hoping this become a quality indicator for clinical practice in the future.
And do you think that more screening would make a difference? Do you think that there are opportunities for intervening and altering that trajectory towards cirrhosis?
I do. And I hate to say it, but the reason why I think this never had attention is we never had an out. Patients had this metabolic fatty liver disease. We tried very hard to address diabetes and hypertension, but we didn't have any pharmacologic agents.
Right.
And today, I think because we have today agents that are able to reverse liver damage and get rid of the fat in the liver, I think that people are seeing that yes, we could diagnose it and we can intervene and make a difference. Like everything else, the sooner you diagnose something, sooner to intervene, the better is your outcome.
So talk to us a little bit about what those interventions are.
So there are different pots. One of them is lifestyle. And we tell our patients, for instance, there was an article in JAMA about sodas in a very large population, almost 80,000 women, and it showed incrementally, almost like a randomized trial, the more sodas you drank, the worse your liver disease. Almost 80,000 postmenopausal women. I think it's a Sentinel paper. So we tell people sodas are dangerous. It's like cancer. You can't drink sugar sodas. Number two, there have been studies looking at red meat. And if you have fatty liver in particular, we should limit your red meat consumption twice a week. There have been other articles recently highlighting that walking, exercising 20 to 30 minutes a day is beneficial, independent of weight loss. And fourthly, believe it or not, people go, oh my God, I can't drink, I can't smoke. What can I do? Coffee. Coffee is good for your liver. We did a review 10, 15 years ago, and it's been shown to be valid that coffee actually is beneficial to the liver. Drink between 2 and 3 cups of coffee. But I got to tell you that's been criticized because, is it really coffee or are these like markers of social economic status? People who drink more coffee, maybe different SES than anybody else. So, and then there's pharmacological intervention too. And, we have 2 drugs approved by the FDA to help reverse liver damage in people who have moderate to advanced fibrosis.
Mm-hmm. So, everybody can be talking about the lifestyle issues and then the actual medications on top of that.
Yeah. But Eve, one thing I worry about is if you look at the medical literature, there are tons of papers talking about the Mediterranean diet. But when I see my patient in the room across from me who's Latina, and I tell him, use more olive oil, unfortunately, our lifestyle recommendations are not culturally sensitive. They're using different type of oils. They're having tortillas, et cetera. So I think we need to do a better job of having culturally relevant recommendations.
Do you have places that you would direct our listeners to obtain more culturally appropriate resources?
We're working on that right now. We're lucky that we have access to a dietitian who works with patients, but we're working on having more culturally sensitive dietary recommendations. It's a big need.
Fantastic. Tell us, as we wrap it up, what are the sort of emerging options? What are the next steps that you're looking forward to in this field?
Well, so what we're looking forward to is we have these medication for metabolic fatty liver disease. The question is, how good are they among Latinos? Because there is a difference in genetic polymorphism. And if you look at some of the data, there does appear to be a difference in response. So I'm hoping to see more specific information about different ethnic groups. The other thing I would love to see is, and I apologize for being so general, but Latinos represent a very heterogeneous group. You have Black Brazilians, you have Black Cubans, you have all these different individuals and different genetic backgrounds from Europe, Spain, Africa. So I think we do a better job of maybe not pull people together in terms of making generalizations, but maybe looking at subgroups and see how we could better tailor our recommendations and therapies for specific individuals.
Great. Well, thank you so much. It's really been a pleasure talking with you today. I'm Dr. Eve Rittenberg, and I've been speaking with Dr. Sammy Saab about MASLD and MASH in Latino individuals. You can find a link to the articles we discussed in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.